Thanks very much, Michael. It's a very nice introduction, and it's very nice to be here, and thanks for the invitation. Michael gave me a very difficult title for the speech because it's about what causes dystonia, which is something which has lots and lots of different answers for different people, and it's a complicated subject, but I hope to sort of just give you a general feel for the area and where scientific research has got to and how that might sort of make a difference and impact on your own experience with dystonia. And I just wanted to start off by trying to answer this question by just giving a little bit of an example about a particular way of thinking about it. So if I asked you what this is, I expect most people would say it's a random collection of ones and zeros, but we know that from computer science, this is something that can mean something. It can maybe represent something. So if we just take that example a little bit further forward, we can think about what this might be. So you can see there's some little pixels there, some little shadings of colour, of light and dark. And if we take that a bit further, on this picture you can start to see some lines. You can start to see some sort of shapes and form to what's happening. And if you take that a little bit further, suddenly you can see that actually it's a person. So we can see that this is representing something which we all recognise as a human being. And then if you take that one step further on, you see this. Okay. So my point about all of that is that we're talking here about levels of description or levels of processing. So it doesn't necessarily make a lot of sense to say that this thing we've been looking at is a collection of ones and zeros, or it's a sort of manifestation of sort of people's struggle over the state, for example, because it's all of those things at the same time. So we're just talking about different levels of processing or levels of description. And that's important because it means that it might be useful at a particular time to concentrate on one of those levels. So maybe the most basic level or the most complex level. So that might be useful when thinking about dystonia, for example, to be concentrating about the lowest level or the most complex level. But it doesn't take away from the fact that all of those things are happening at the same time. And if we just concentrate on one level and think that's all it is, then often we lose an enormous amount. And the commonest thing that gets lost in all of that is the human aspect of the illness. So if we just take this analogy and put it forward in dystonia, so at this most basic level. So that's the level of thinking about genes and dystonia. So I'm sure you're all very familiar with genetic discoveries. You hear them in the news all the time, not necessarily about dystonia, about lots of different conditions. And genetic work is often said to hold the key to illness in amongst human beings, that if we understand the genetic code, if we understand our genetic code and how it might go wrong, that will give us the answer to everything. So that's not necessarily true, but certainly genes and genetic understanding can give us a lot of information about a particular illness and how it might affect people. And it's also quite important in understanding the hereditary nature of some illnesses, and therefore quite a complicated discussion of what the risk is for future generations in a family where dystonia is present. So back in 1997, there was the first discovery of a dystonia gene, and it was called DYT1 or dystonia 1 because it was the first one. And that gene turned out to be quite an important gene because it's the commonest cause for young people to get what's called primary or isolated dystonia. So dystonia where there's not any damage or degeneration to the brain, it just seems to arise out of a normal-looking brain, and it produces dystonia. And so that condition is something where people tend to get young onset of dystonia when they're about 8 or 9, sometimes a little bit later, generally starts in the foot or in the hand, and then tends to progress, and people get generalized dystonia. So that condition is important from a number of points of view. So firstly, it shows that genetic problems can be a cause of dystonia for some people. But it also introduced this idea that in dystonia, it seems like if you carry a gene that might cause dystonia, it's very common for people to have that gene, other people in the family to have that gene, and not actually get dystonia. So when that DYT1 gene was discovered, and people went and tested that gene in other members of the family, including people who didn't have dystonia at all, they found that about 70% of people who carried this particular gene problem had no symptoms whatsoever, and they were never ever going to get symptoms either. So it shows that just finding a gene abnormality doesn't tell you all you need to know, because that's just one gene out of millions of genes that we have. So there's this complicated interaction between a gene problem and all of the rest of the genes you have that can mean that some people can carry a gene mutation, and never develop any problems. And we see that idea repeated again and again when dystonia genes have been found. It's very common to find other members of the family who carry that gene but have no symptoms at all. So, in a sense, if we did understand how those people are staying well, despite the fact they carry this gene, that would be important information. And there is work that's being done about trying to understand the protective genes that might stop people with these dystonia genes actually getting any symptoms. There's a slightly unhelpful dystonia gene classification thing where I can't remember now where we're up to, I think it's DYT 30 or something like that. So there's a number of genes that have been discovered in dystonia. And that can sometimes feel like there must be a genetic cause for all dystonia. But lots of those genes are in single families. And so for more typical types of dystonia, say typical cervical dystonia, often the genetic basis of that is very difficult to know. And that makes it quite difficult to counsel people about what the risk might be of relatives who, if you have a relative who has cervical dystonia, what's the risk of other members of the family being affected? What work which Professor Hutchinson and colleagues have shown is that even within cervical dystonia, it seems to be the case that there's unaffected people in the family, so people who don't have any symptoms at all, who are carrying some sort of marker that there probably is an underlying gene problem there, but they're not showing it. And it's also the case that for gene problems, there may be lots and lots of genes all interacting together. So we know that's the case from things like high blood pressure, where high blood pressure does seem to run in families, but it's very unusual to find a single gene, and there might be thousands of different genes that all interact together to slightly change people's risk. In certain genetic conditions, for example, there was a recent announcement of a study like this in Huntington's disease, there's the idea that if you did have a specific gene problem, then it might be possible to maybe turn it off in some way by doing some sort of gene therapy. So this is something that's been promised for decades, really, but has not really come to fruition yet, except in very specific areas. But I think that it is likely that over time that's going to be something that may happen. But it may help a small proportion of people, because there's only a small proportion of people who have a single gene problem that's causing the dystonia. And more typical dystonia is probably a complicated combination of genetic risk, so lots and lots of different genes added together, plus other factors like environmental factors that all add together that might increase somebody's risk of dystonia. So genetic work is important. It does tell us some important things about dystonia, but it's only, I think from the treatment point of view, it will be relevant for a proportion of people in the future, but not for everybody. But understanding more about the genetics will help us understand more about the condition together. So if we think about the next level, this sort of pixel level, so I was wanting to talk a little bit about neurotransmitters and dystonia. So neurotransmitters are chemical messengers. So they're the chemicals that are released from nerve cells in the brain, which communicate from one nerve cell to the other. So these transmitters are very, very important to the way the brain works. And we know that there's particular types of dystonia where they're really, really important. And the most obvious condition for that is a relatively rare condition, which is called dopa-responsive dystonia. Maybe something you've heard of before, but that's a condition where there's a genetic abnormality, which means that the brain doesn't produce enough dopamine. So there's a reduction in the amount of dopamine around. So dopamine is a very important chemical in movement. That's the chemical that's lost in people who have Parkinson's disease, for example. So in people who have this dopa-responsive dystonia problem, typically at a young age, they develop dystonia and sometimes slowness of movement. And sometimes it can be very, very severe. And they typically have what's called a diurnal fluctuation. So in the morning, things are relatively good, but by the end of the day, they're terrible. I certainly remember one patient who was about 8 or 9 who would be able to walk to school in the morning, and at the end of the school day, she'd be in a wheelchair because the dystonia had become so severe. So that condition is important because it's a very treatable condition, and effectively it's a curable condition with dopamine. So when you give those people with dopa-responsive dystonia dopamine, which is just a tablet which is used for the treatment of Parkinson's disease, the dystonia more or less completely goes away and stays away more or less forever. So it's a very important condition to recognise and to treat. But it's also telling us, it's a very, very rare condition as well, but it's also telling us something about dystonia, and maybe that more typical forms of dystonia dopamine might be an important chemical in that as well. So this DYT1 dystonia I was talking about, now with sort of further genetic and molecular studies, it seems to be the case that DYT1 gene is involved in some way with the way that dopamine and other chemicals are released at these junctions between the nerves between nerves, so at synapses. So, and it is the case that some people with DYT1 dystonia and more typical forms of dystonia can sometimes get a little bit of benefit from taking dopamine. That's not a common effect, and the effect is usually quite small, but it's perhaps showing that dopamine is a relevant chemical in dystonia more generally. The other reason why that chemical is important is that we know there's another form of dystonia which is caused by blocking dopamine in the brain. So there's a group of drugs which are generally used for the treatment of severe psychosis, like in schizophrenia, but they're sometimes used for treatment of dizziness and also as anti-nausea drugs. And they block dopamine receptors. They block the receptors in the brain where dopamine binds to. So those drugs can be very important. They can be very useful drugs, particularly in the treatment of schizophrenia. But we know that a small proportion of people who take those drugs in the long term, usually for years, will develop dystonia. So it's something called tardive dystonia. And so sometimes people can also develop more fidgety movements around the mouth called tardive dyskinesia. So it seems that blocking dopamine in the brain in a proportion of people seems to do something and change the circuitry in the brain, and that can be a cause of dystonia. It's a difficult condition to treat because even when you stop the drugs which seem to be causing it, it tends to stay, the dystonia tends to stay. But there are other ways of treating it, for example, with other medications and also with deep brain stimulation surgery. But the point is it's showing that these chemicals can be important, and particularly dopamine is important. It's also, this neurotransmitter level is also why particular drugs are used that can treat dystonia. So, for example, anticholinergic drugs, so drugs that block another chemical called acetylcholine. That's a mainstay of treatment for dystonia, and certainly before botulinum toxin came around, that was a main treatment for all different types of dystonia. It's often, though, there are some people who take those drugs and they do very, very well, and other people who take them and they don't get any benefit, or they might get side effects. So there's individual differences in all of these things, and they're often it's an issue where you need to try a medication and see how it goes. And just as a general piece of advice for medication, it's always the case that when a neurologist gives somebody medication for a condition, it's very difficult to predict exactly how that person's going to react. We know that these drugs can work in some people, but that doesn't mean that they're going to work for you. And nobody has a crystal ball, nobody's able to tell that in advance. There's also, comes in every drug packet, a huge list of side effects that are listed on a piece of paper. And that's quite frightening as well, because it sounds as though these are the things that you're going to get if you take this drug. But that's not true. These are the things that can happen to some people when they take the medication. So whenever you're starting a new medication, it's important to understand why you're being given it, and understand usually that the medicines that are being given for things like dystonia are symptomatic treatments. So they're trying to help with the symptoms. So if they make you feel worse, then they're not really helping. And so there should be an approach where you start at the smallest dose possible and you gradually increase the dose to see whether it's helping your symptoms. And if it's not, or it's causing side effects, then you may choose to stop it. So it's a collaborative thing. And the neurologist can't tell in advance exactly how you're going to respond. So you need to tell them that it's not working, and you need to be able to have that communication and know that you're able to stop the medication if it's not helping you. It's a shame that I think must be maybe 40, 50 years since a new medication was developed for dystonia, leaving to one side botulinum toxin injections. So there's probably a lot more to do at this level of understanding how the chemicals that go around in our brain are interacting, how they're causing dystonia, and even just simple things about how anticholinergic medications might work. But I'm sure there is room there for more medical treatments for dystonia over time. So just moving up another level, just to talk about something called brain plasticity. So plasticity is the way in which our brains change in response to experience. So it's how we learn anything. So when we're born, we have a fairly blank canvas in the brain. There are, obviously, has basic functions, but it's our experiences over time that help mould that, and they change the structure of our brain. They change the way it's working. So this is a very useful thing. Without brain plasticity, we're nowhere. We couldn't learn anything. We couldn't learn a new skill. But there's an idea which has been around thinking about dystonia, that in dystonia there's a problem with the way this brain plasticity system's working. And in a sense, it's overactive. So there's too much plasticity. It's turned up in a way. So that's been something which I've been involved in looking at with lots of other people, where when you do things to the brain which would usually in healthy people produce a change of a certain amount, when you do those same things to people with dystonia, the change is enormous. So you get a much, much bigger change. So the idea behind thinking about plasticity is that when people are going through their lives, when they're developing their movement skills and motor skills, all of these connections in the brain are changing, and they continue to change throughout our life. They need to be reinforced all the time. And that in people with dystonia, because this whole system is turned up, it's amplified, you start to get abnormal connections between nerve cells developing, particularly in bits of the brain that control movement. And if you think about it, that might explain why in dystonia, what people often experience, for example with dystonia of the limb, is that they may, if they reach out their arm, they'll do that movement. So it's not that they can't do that movement, but what happens is a whole lot of other muscles, which are not involved in the movement, turn on as well. So as well as the movement, there's a whole lot of other things happening. And so the movement goes wrong, and abnormal posturing occurs, because muscles which would usually, so if you want to move around a joint, for example, if I want to do this, I need to turn on muscles here, but I also need to turn off muscles here, otherwise it's stuck. But in people with dystonia, what happens is you get co-contraction. So if you want to do this, you see muscles over here turning on as well. So that's an example of where the whole system seems to be connected up in the wrong way, and there's too much activity. And that's something which is sometimes described in neurology speak as sort of overflow of muscle activity. So there's the core muscle activity the person wants to do, and you can see those muscles turning on. But then there's this overflow of a whole load of other muscle activity, sometimes in other parts of the body as well. So there's an idea that potentially with treatment, you might be able to turn down this abnormal plasticity and maybe get the system to relearn a more normal way of moving. So studies have been done, for example, using methods of brain stimulation, so non-invasive brain stimulation. So that's where you're trying to stimulate the brain with electrical activity, sometimes magnetic activity, and you're trying to change the way the networks are working. Those studies have not really shown a great deal of change or improvement in dystonia, but it does seem likely that deep brain stimulation surgery does work on some level on this plasticity system. So when people have done studies in people who've had deep brain stimulation surgery, and they've, in an experimental way, sort of measured the amount of plasticity in the brain before the deep brain stimulation surgery, and then they measure it afterwards, it seems that it's abnormally turned up before, and then after the surgery it seems to be suppressed. So maybe that's somehow allowing the brain to relearn or retrain itself. And that's theoretically where there's a benefit, or there could be a benefit, from physical approaches to treatment, so physiotherapy or rehabilitation and retraining. And I know you're going to hear about that a little bit later today as well. So it's trying to work at this level of brain plasticity. So just one more level up. Just thinking about networks. So we started at a very basic level talking about genes and then the chemicals that are involved in transmitting between nerves, and then about this plasticity system, the way the brain changes in response to stimuli. And that's producing a network. It's producing a complicated, very, very complicated motorway network of communication between different parts of the brain. And all of that is needing to work together in order to produce normal movement. As you've heard already from Professor Hutchinson and others about the research that they're involved in, there's a key role for sensation in all of that. So we tend to think of movement as just muscles, but it's not at all just that. Our brains need to know where our bodies are in space in order to move. They need to be able to predict what's likely to happen if we move. So we need visual input, we need sensation input as well. And all of that together is involved in producing normal movement. So I think we lose sight of the fact, because movement, for people who don't have dystonia and don't have movement problems, because movement is generally an automatic process and it's just so easy, we don't tend to think about how complicated it actually is. So I thought I'd show you a little video about that, which is a video from the Robot World Cup, which is a competition which is held every year. The video I have is from 2011, but I can tell you that things haven't changed much since then. So this is a competition held every year from the leading universities around the world, and they have to build robots to play football. So that's the idea. They probably haven't got anything better to do, but so you can see that it's slightly pathetic. He does actually score in the end. It takes a long... See, he's just stepping in place, really not doing much defending. A lot of applause. So, as you can see, as you can see, it's a bit pathetic, and that's the greatest minds of the world building robots to play football. So the point of that is that movement control is very, very complicated. We think it's easy because usually it works, but it's very, very difficult to program. So you can build a robot that can beat anyone at chess, or remember whole libraries of information. But actually, to make something move normally is very, very complicated. And the reason for showing that is it reflects the level of understanding we have about this really complicated thing of movement control. I mean, we know that these networks of nerve cells which help us move are abnormal in some way in dystonia. So we can see that they seem to be abnormally active. So when people with dystonia move, they seem to turn on lots and lots of bits of the brain which wouldn't normally be involved in movement. We know that the sensation input, the processing of sensation input from the body, whether that's visual or touch sensation, seems to be abnormal as well. And so you can imagine a system which is trying to move, but the information it's getting about the state of the body is abnormal, it's corrupted, or it's distorted in some way. And then the messages it's putting out are also distorted and corrupted. And that whole thing together makes it very, very difficult to control movement normally. And it makes it very difficult to learn how to control it better. Because if the feedback that you're getting is distorted and corrupted, then it's hard to learn. when we're learning new things, whether it's to learn to play a musical instrument or learning to walk or learning a new language, we rely on feedback. We rely on doing something and then picking up a change that we've made and learning whether it was the change we thought it was going to be, or maybe something different happened, in which case we have to change what we did in the first place. So it's this loop of trying to pick up information from the environment and build that into how we move. And you can see how if the different bits of that, the sensation and movement bits of that, are not working properly, it becomes difficult to change. There may be ways around that, though. So, for example, that's where, again, I think there's a role for rehabilitation. So having somebody external to you, being able to reflect, actually that this was wrong, maybe you could change this in a different way, that might help. Sometimes changes in sensation can help. So there's this well-known phenomenon of the sensory trick in some people with dystonia, where, for example, somebody with neck dystonia might be able to just touch their face, or even just think about touching their face, or go to touch their face, and the posture reverses. And you can maybe think about that as giving the system a bit more sensory information, and it's allows the system to build on that and correct the abnormal posture. So I think intervening at these sort of network levels is very interesting, and I think we can do it potentially from physical and sensation sort of training. It's potentially something, an additional way in which deep brain stimulation surgery can work. But understanding these networks, like I showed from the video, is complicated. But I think there's a lot of progress which is being made in that area, particularly as computer modelling of things becomes better and better and better. We can better model these sorts of networks and know how they may not work and how to make them work better. So just coming to this last level, I think that, like I said right at the beginning, the one thing that sometimes gets lost in thinking about why dystonia happens is the human aspect of it. And in the end, that's all that matters, because what doctors want to do and what you want, doctors don't want to treat robots. We're interested in treating people and helping people. And so there's an issue, though, I think, in talking about psychological factors and emotional factors, because there's an unfortunate stigma in society that when you might talk about things which are more psychological, there's an immediate feeling of thinking, well, maybe you're talking about something that's not real, or you're saying that I'm doing this to myself, or there's a sort of negativity about it, and and I think that's partly due to the words in which we use to describe these things. So, I think most of us would say at some point in our lives, I feel a bit depressed today, or I feel a bit down, or I feel a bit anxious today, or I'm a bit obsessive about that. But that's really talking about normal emotions, isn't it? But that's completely different from what it actually means to have major depression, or what it actually means to have an anxiety disorder, or to have a obsessive-compulsive disorder. So those are fundamentally different things. So with normal emotions, we're generally taught to say, well, just need to pull yourself together, it'll be all right. But when emotional problems are happening in the context of illness, that's often not possible. I'm not trying to say that it doesn't matter how you feel about things, or what your level of motivation or optimism is about things. But it's not just that. Sometimes people need additional help to deal with these sorts of consequences, or the nature of having dystonia. I think there's two ways in which emotional things change on the emotional level. First of all, there's a thing about having what is usually a visible disorder. So lots of medical problems that people have, whether it's high blood pressure or so on, they're not really visible. You wouldn't know it walking past somebody on the street. But if you have a movement disorder, like dystonia, typically, it's obvious to everybody. And that's very difficult, and it's particularly difficult in the way that we live, in the way that physical features are seen as an important marker of how worthy a person is, or how worthwhile a person is. And I think there's often a link made, a completely incorrect link made between movement problems and intelligence as well. So as soon as you have a movement problem, if you have shaking or you have an abnormal posture, people start treating you like you're lacking in intelligence in some way. So there's all of these things which add to the burden of having the disorder itself. But I think there's another level also to think about this, which is that the brain and the mind are not separate things. There's not a bit of the brain, which is the mind, and the other bit, which is the brain. They're all a connected structure, just as I was saying, it's all a network. So it's pretty likely to be the case that if the brain is going wrong in some way, it might affect other functions of the brain, like mood, etc. So there is evidence in people with dystonia that, for example, in the run-up to developing dystonia, rates of depression and anxiety are higher than you'd expect in the normal population or the healthy population. So even before somebody develops their movement disorder, there may have been some change in their mood, which is probably reflecting the underlying process going on in the brain. So I think recognising these factors and recognising that they are real, that they can be part of the illness and they can be an important component of what's going wrong, is important, because it means that, first of all, just validating them can be helpful, and to know you're not going crazy, not losing your mind, that these things that happen commonly as part of this sort of illness, but also potentially involving with treatment as well. It's not necessarily easy to get access to good psychological treatment, for example, but it is something which can help some people. It's not a panacea, it doesn't fix the whole problem, but it's another aspect, if you like, of treatment which can be particularly helpful for some people. And I think that, with events like this and these fantastic photos, for example, and that's all of these things are ways of trying to change societal views of people who have physical disability, who have visible differences in the way that they move, and to try and make it easier for people to live their lives despite that going on. So I hope I've been able to show that this question about what causes dystonia, what is dystonia, it's a complicated one, and you can think about it on lots of different levels. But the most important thing is that all of those things, that all represent one thing, and that's a person who has dystonia. And I think there's progress being made in trying to understand these different levels, and that's going to lead to improvements in treatment over time. I'd be very happy to answer any questions, and thank you very much for your attention.